All right, C. Weber, this one's for you. We're talking about chronic inflammatory demyelinating polyneuropathy. CIDP is an autoimmune disorder that affects the peripheral nervous system. So anytime you hear me say a disorder that affects the peripheral nervous system, think lower motor neuron disorder. And so you're going to see lower motor neuron signs like weakness, fasciculations, decreased deep tendon reflexes, and the like. It can affect motor and sensory neurons and is characterized by inflammation of the nerves and nerve roots, because that's what makes up the peripheral nervous system. And this inflammation then leads to the destruction of myelin, which then slows nerve signals, leading to weakness, numbness, and tingling. And it is not well understood what actually triggers this autoimmune response to attack the peripheral nervous system. The proposed hypotheses for the source of inflammation is a combination of both humoral immunity and cell-mediated immunity. So humoral immunity is when B cells produce antibodies that target the myelin surrounding peripheral axons and then degenerates it. So this is including those at perinodal junctions, or the proteins at perinodal junctions, including neurofascin 155 and contactin 1. The cell-mediated immunity is when T cells and macrophages essentially attack myelin, breaking them down and eating it, which then can lead to these T cells and macrophages infiltrating the peripheral nerves themselves. So the clinical manifestations of CIPD is weakness, which can be progressive or relapsing remitting, which we'll talk a little bit about later. It's typically symmetric weakness that affects both the proximal and distal muscles of both upper and lower extremities. The sensory loss is going to include things like numbness and tingling and reduced sensation, including proprioception. So proprioception is our brain's awareness of how our joints are positioned in space. And then the course of CIDP is it can be monophasic, meaning that there's only one episode where we have reduced sensation and greater weakness that can last up to 1 to 3 years. This is usually cases where initially they think that the person has Guillain-Barré or acute inflammatory demyelinating polyneuropathy, and then it ends up lasting 1 to 3 years because it wasn't Guillain-Barré, it's actually a monophasic CIDP. It can also be recurrent with relapses or remissions, similar to the way that like MS has relapse remitting, but this is just obviously not the same as MS because MS attacks the central nervous system and not the peripheral nervous system. But it can also be progressive, and so it can also have the effect of having a continuous worsening of symptoms. Other symptoms of CIDP, obviously we talked about loss of reflexes, just as a result of the disruption of the reflex arc, which is typical of lower motor neuron disorders. You can have fatigue as a result of the muscle weakness, nerve pain, and then balance and coordination issues due to the loss of things like light touch, deep pressure sensation, and proprioception. The diagnosis of CIDP is usually through a thorough clinical neurologic exam, so assessing sensation, motor symptoms, assessing strength or weakness of myotomes, assessing deep tendon reflexes, and then also a combination sometimes of both nerve conduction velocity studies and electromyography studies. They can take biopsies of nerves themselves that are in the distribution of the sensation or muscle loss, and then they also can do lumbar puncture to harvest cerebrospinal fluid, and what they're looking for in that cerebrospinal fluid is just inflammatory markers that indicate that there is an inflammatory process going on, but not necessarily any one of these things is going to lead to a diagnosis of CIDP. It's usually a combination of several or all of these things. Treatment for CIDP tends to include immunomodulation therapies. So frequently I see these more commonly in like if there's a relapse or like an active point of inflammation, you'll have injection of IVIG, which we've talked about before in the case of like Guillain-Barré, corticosteroids, which in like their whole job is to eliminate inflammation in the body, and then plasma exchange, which is similar to IVIG. It's just usually not on hand as commonly as IVIG is. Pain management, particularly for like the neuropathic pain, which usually is going to be through the prescription of something like Lyrica or like pregabalin or gabapentin, essentially. And then PT and OT is also common. So how do we treat this in physical therapy? It is not as common of a disease, at least in my neck of the woods. And so I have seen several patients that have CIDP, but because it is not as prevalent, there don't tend to be these like CPGs or clinical practice guidelines. So I treat it essentially like I was treating anyone with a progressive neuromuscular disorder. I will do progressive strengthening as indicated, but I do not want to over fatigue them because I don't want to cause excessive delayed onset muscle soreness that's going to make them incapable of doing their daily activities, which means they're probably going to end up getting more atrophy of those muscles. Sensory reintegration, and what I mean by that is we have three sensory systems that contribute to our balance. Your somatosensation, which is going to be your light touch, your deep pressure, your proprioception, and then your vestibular system and your vision, okay? So I try to teach them essentially how to overutilize their visual and vestibular systems so that those two can compensate for the lack of somatosensation. And then I also just want to monitor for any signs of worsening weakness or sensation over the course of plan of care, because if they then begin to be in another acute inflammatory process, we want that under control. So that may require us to refer them back to their PCP or their neurologist or something like that. And then obviously if they require an assistive device or AFOs or even CAFOs or something, making sure I'm getting them hooked up with a good orthotist so that way we can get them the devices they need and then train with them so that way we see that way we basically just get them used to using those things to improve their function. Thank you, C. Weber, for suggesting that I go over this. If any other people or followers out there want me to cover a specific topic, please comment or message me directly. I would love to talk about any neurologic disorder that you guys know about, are curious about, or perhaps are diagnosed with yourself.